Well, good morning, everyone. I'll just take a second and introduce Eric here. Eric Klineberg is one of our dear friends here from the foundation. I know Bob and I know him very well and have collaborated on a ton of research, but maybe more importantly, on a personal note, Eric's just lovely to hang out with. He's a great friend, true to the core. Recently, Eric accepted the University of Texas in Houston, and we'll be moving there probably in a month or two, I imagine.
Yep, couple months.
Be the chief
So they're breaking.
here at the department, and we're proud of you, Eric. It's a great move for you. And Davis in California will be very, very sad to see you leave, but we're happy for you and your family. One of his sons just got into school there, and hopefully we'll be going there in the fall as well. So maybe I'll be a little closer to some family too. So, anyways, without further ado, Eric's done a great job of making himself the complication guy. So, this is going to be focused more on cervical deformity. We had a really nice overview of cervical deformity several weeks ago, and I thought this would be a great addition to that lecture series, focusing more on how stuff goes bad sometimes and how we can mitigate that. So without further ado, Eric, thank you very much for being here this morning.
Thank you, Greg and Bob and everyone else online. It's great to be here. Thanks for having me. You have to be very careful when you start getting interested in research to pick something that you want to be known for. I would caution you against complications. It does get your friends giggling at you when they introduce you. So just be thoughtful as you go forward. I thought today we talk about some of the data that we've gotten from the ISSG about cervical complications, and Justin Smith has really led the effort, but we've certainly worked closely together to look at this and then go through some of those complications and maybe what are we doing now to help mitigate some of the things that we've seen, and how can we continue to work on making things better. Here we go. Here are my disclosures. None of them are relevant to this talk specifically. So cervical alignment deformity, we know that they can have a significant impact on our patients, and surgery is complex and risky. However, we also, the cervical deformity literature is relatively limited. There's a limited discussion about definition, assessment, optimal treatment, outcomes, et cetera. And so really understanding what we need to do for our patients is a little bit complicated. We have looked to see what the health impact of cervical deformity is on our patients, and we looked at this EuroQual 5 questionnaire. And if you look, adult cervical deformity ends up being right on par with emphysema and blindness in terms of its overall impact on our patients. So we know that it's a big deal. If we look at how those patients have done, at least in short-term follow-up, this is a one-year follow-up that was done, again, through ISSG work. You can see from baseline to 1 year, we have a decrease in NRS, we have a decrease in NDI, we have an improvement in our EQ5D, and we have improvement across all these other subdomains in the EQ5D. So we know that we're also making these patients better with our surgical intervention. And if we look at the difference between those that did the best or did the worst and looked and see what they did at 1 year, we can see that we do have this kind of cutoff between these two that seems to be mostly focused on complications. And so if we have one major complication, it really pushes us from the best group to the worst group. And so understanding these complications and mitigating them is critical to making sure that we have the outcomes that we want for our patients. Again, nothing surprising. If we look to see what are those complications that we worry about, and this is assessment of early complications within 30 days of surgery in about 80 patients. And what we looked is what we did is categorized all the complications that occurred and try to understand, first of all, what was happening, when was happening, and then start thinking about what are the things that we can do to make them better. If we look at here are the most common complications: dysphagia, deep wound infection, new C5 motor deficit, respiratory failure, new motor deficit that was not C5, sensory deficit, and superficial wound infections. And if we look at these, 43% had at least one early complication, either a major or minor complication. And this is really what we need to focus on when we think about fixing things. If we look at who did they happen to, and the answer is there was no difference in early complications between age, smoking, BMI, other morbidity, previous spine surgery, etc. Really, none of these were significant when we look overall at whether or not these we could predict which ones of these patients would end up with an early complication. If we look to see what happens, if it happen when we do anterior or posterior, there seemed to be a greater rate when we had posterior only or combined approaches, 73% in combined approaches, probably talking about the complexity of the surgery. And then again, dysphagia was also more common when we did combined approaches. And so when we think about this, again, kind of my takeaway from this is be cautious when we need to do these combined approaches. And sometimes you have to get the alignment right. But when you're doing that, you need to start counseling your patients and potentially yourself and your staff about the fact that you are going to see more complications early, and are they worth the intervention? In summary, right, we need to continue to follow these patients, and then we're also going to see some delayed complications, including pseudoarthrosis, rod fracture, adjacent level disease, and then PJK and DJK. And again, those complications that we follow late sometimes require an early, larger operation like a front back to prevent pseudoarthrosis. And again, we just need to think about the trade-off, that early complication trade-off for the late complication trade-off. We look at mortality overall and death rates. It turns out there's only one within 30 days of surgery, but we're certainly going to see higher mortality with longer follow-up. If we look at, and then this is a slightly longer follow-up, so this is now our late follow-up, so all-cause mortality rates assessed at mean year, 1.5 years following surgery. And overall, we saw significant morbidity. And so comorbidities per patient were about 1.8 per patient, and 80% at least had one comorbidity. So these are, in general, folks that get cervical deformity are sicker, are older, and more complex surgeries to take care of. And again, some of their deformity may be, in fact, coming from that sarcopenia and loss of head control, which is indicative of not just cervical disease, but maybe of their overall health, quality of life, and life status. If we look here on all-cause mortality, there were 11 deaths that occurred after a year after surgery, so almost 10%. And there was a wide range of causes: pneumonia, MI, sepsis. So again, some of this is likely related to age and to comorbidities, but still really a staggering rate. 10% of the people that we operated on are going to be dead within 1 year. Again, clearly too high for what we have. So final results, so 9.2% was a rate, 1.0 follow-up. All-cause mortality for hip fractures 35%, and for dental fractures is 25%. And so could this be similar to that? Could this have an issue that really kind of starts being prognostic for overall health status of a patient rather than just being about the surgical intervention? If we look at what happens at 3-year follow-up, complications at a minimum of 3 years, so there are 103 complications. So for a 57% rate of patients having at least one complication. And again, the complications are exactly what we talked about: dysphagia, DJK, instrumentation failure. Again, some combination of both early and late failures. Most complications were early: dysphagia, cardiac events, respiratory failure, nerve root deficits, infections, and delirium. And then common delayed complications, DJK and instrumentation failure were the two most common that we saw in our series. Well, it's great. Perfect. We can categorize it, but what are we going to do to try to prevent it? And so I'm just going to go through 3 major issues that we see, both early and late problems. So neurologic deficits, rod fractures, and DJK. And what are some of the factors that we're currently thinking about to try to prevent these problems? Neurologic deficit is a huge issue. So a third of early complications were new neurologic deficits, 14% incidence of new deficits. However, there were no spinal cord injuries or new spinal cord deficits, at least thus far in the series, although I suspect, just like everything, all complications occur over time. There's a couple of things that we can do to help prevent this. So awake fiber optic intubation can be good for high-risk patients. This is a patient with significant ankylosing spondylitis, and so getting intubation, getting that proper is very difficult. Having an anesthesia team where we avoid hypotension, and making sure that we have enough people and help for positioning. I really am a big proponent of avoiding excessive taping the shoulders. And so I think sometimes the C5 nerve root palsies are as much about a brachial plexopathy as they are about the C5 root being impinged or tractioned at the level of the cervical spine. So it's a bit of both. And so we need to be careful that we're taping down the shoulders to what we need to see carefully, but that we don't actually need to see all the way down to T1 or T2. And then getting pre-positioning baselines, I think is also critical. We need to know what we're starting with, and so we can make sure that we're maintaining that baseline. Most of the time, cervical deformity it's not just a malalignment of the cervical spine, but rather it's malalignment with myelopathy. And so these are patients who already have sick cords or sick roots. And as we start manipulating them, we need to make sure that we know what we have. I think the other bit that's changed dramatically is the posterior pedicle subtraction osteotomy. 15 years or 20 years when we first started our careers as spine surgeons, really a C7 PSO was really the procedure of choice. It avoided the vertebral artery and it allowed us to decompress the canal and put things in the right place. However, that shortening procedure really caused a lot of problems with the neurologic deficits. If we look at 3-column osteotomies for correction of cervical deformity, nearly 60% have at least one major complication, and 17% had 70% had at least one complication, either major or minor. And most of the complications in those series were neurologic. And so, again, we see patients like this. We think about C7 osteotomy. What we end up with, and what we have problems with, is intrinsic hand weakness. And this is a classic picture of a hand with intrinsic wasting because of compression of that T1 nerve root. And what you can see, what we do is we stuff those two nerve roots together in the same foramen. In the cervical spine, this is unfortunately poorly tolerated. And additionally, we don't have any neurologic or neuromonitoring warning that tell us that we're seeing this problem. So we do the operation, everything goes great, and then patients wake up with this intrinsic hand wasting and weakness, and then going back to try to fix that problem turns out to be just not possible and not very easy. And intrinsic hand wasting is a real problem in terms of living your daily life, grabbing keys, grabbing coins from your pocket, etc. So this is a big deal. When we look at where the neurologic injuries occurred, based on the osteotomy site, you can see that the rate goes down as we move away from C7 and T1. And so at C6, there was essentially no rate of complication. C7 and T1 was where we saw the highest rate of C8 nerve root palsies. And then if we get lower down T2 and T3, you can see the rate then starts dropping precipitously. And so this is really where we want to focus on our osteotomies. And most of the time when we're thinking about doing a pedicle subtraction osteotomy in the cervical spine, we're actually talking about doing it in the upper thoracic spine. And this helps mitigate, again, this complication of C8 and T1 nerve root palsies. What about rod fractures? So there's a limited literature on rod fracture in cervical spine surgery, but we have lots of data in adult thoracolumbar deformity that when we're doing significant osteotomies and corrections, that we place a lot of stress on our implants. And this is a paper that looked at 200 patients with minimal 2-year follow-up and rod fracture. And you can see the rod fractures really occurred all over the place, but where they occur most frequently is around these osteotomy sites. So 25% of patients had a PSO, but if you had a PSO, you had 61% of those patients were likely to have a rod fracture. And so it's the destabilizing of the spine and then compressing things together really is what gives us the highest risk of implant failure. And mostly, and again, it's just, this is a race. We're a race between holding the spine stiff and in the appropriate location and the spine healing together in the appropriate way. And the greater the destabilizing procedure, the greater the risk that we have that things don't heal together well. And so what have we done? And the answer is we've started placing accessory rods. So either junctional rods here that are nested within the implant, or rods that are completely separate, have their own iliac bolts and have their own connection pieces. And so what about for deformity? So if we could do a 3-column osteotomy for deformity, we can also end up with rod fracture and rod failure. And so how can we protect and mitigate this? And again, we can use very similar strategies. So these are using supplemental rods across this area. You can also use cobalt chrome knobs or stiffer rods. We also have a mix of 3.5 and 4 rods that we can place across the osteotomy sites. And so if I'm doing an osteotomy at the cervical thoracic junction now, I'm going to use larger rods crossing those sites, and then a minimum of 3, if not 4 rods to help connect things together properly and compress them and put them in the right place. So all of those things can make a difference for osteotomy correction. What about DJK? As we know, with proximal junctional kyphosis, this is probably something that we caused. And so by doing a better job of realigning our patients with these powerful implants, we have placed the spine into better positions. We've better able to operate on more complex and patients, both deformity-wise and medical-wise. And so with those more complicated patients, more complicated corrections, we've also ended up with pulling them and holding them in a rigid position, and then having them create a junctional problem above that construct. And it turns out that we see the same thing with cervical deformity. As we do a better job of correcting the cervical or cervical thoracic deformity, we're placing a lot of stress on our distal implants. And with that, we're having a lot of distal junctional failure. And you can see in this case, we cement augmented the lower screws, but even despite that, the patient ended up falling into kyphosis. And again, these can be fairly sobering surgeries in that we're focusing on the cervical thoracic junction, and all of a sudden we have screws into the pelvis. And sometimes finding a distal point of fixation is incredibly challenging. There's a couple things that we've done to prevent this as well. Teriparatide injections have been a mainstay. We really want to think about improving or maintaining the bone quality. We think about LIV, distal to the apex of the correction, and often what I will use is kind of the Schurman's rules. And so the Schurman's rules are a line drawn cephalad to the end of the L5S1 vertebral bodies. And you look for the last lordotic segment that's bisected by that line. And that ends up being quite low. So T3 or T2, and you can see in this case, it didn't even save us here. We can think about vertebral augmentation or LIV up angle screw technique. And this is, I don't use the LIV up angle technique, but I think it's intriguing to think about placing a screw bicortically through the inferior portion of the vertebral body. And the idea is that when the screw is placed in this straight ahead trajectory, it can easily windshield wiper into the rest of this vertebral body, falling into increasing kyphosis. But if the screw is angled superiorly, that potentially it can prevent that windshield wipering because it's going through these multiple cortical pieces, multiple cortical bits of bone. And so that can make a difference, and at least theoretically sounds like an intriguing idea. This is what it looks like in real life. These are some expandable screws that are placed through those end plates. And the idea is to prevent these screws from windshield wiper or toggling through that vertebral body. So in summary, cervical deformity has a huge potential to improve HRQLs in our patients, but it has very high complication rates. And if we look at the difference between those that did the best versus those that did the worst, really complications are the deciding factor that push us from one to the other. And most of the early complications are cardiopulmonary. And so this is, again, this is medical optimization. Dysphagia, which is a combination of correction and potentially preoperative optimization and preoperative evaluation. Neurologic deformity, neurologic complications, which is a combination of technique, neuromonitoring, and then selecting the appropriate levels for osteotomies. And then infection, again, which is a combination of health status of the patient and then also intraoperative techniques, including vancomycin, that can improve things. The delayed complications are DJK and implant failure. Again, hopefully will be solved with improved instrumentation and instrumentation techniques, but are also likely related to the age and complexity of the patients and the amount of correction that we're achieving for these patients overall. We're also seeing late pseudarthrosis, neurologic and dysphagia problems, again, probably related to those failures and related to the recurrence of the deformity. And clearly further research is needed to define patient selection, optimal treatments, and techniques to decrease these complications to do the best job we can for our patients. So I think that's it, Greg and Bob.
was awesome.
Absolutely.
Any questions from the group?
Thanks, Eric. That was phenomenal.
Sure thing, buddy.
Thanks for joining us, Charlie.
My pleasure.
Hey, Eric,
Don't-
why do you think
Complications suck.
the
Yes, they
complications are so much higher? I mean, clearly, like a lot of these complications, like once you parse it down to were patients that had usually posterior surgery or anterior posterior surgery, like when you treat, focal deformities, because we do have some of those in the database as well, where we did like anterior only. I feel like those patients are a little bit of a different animal. Would you agree with that, or do you think that's false?
Yeah. No. I think so. We've done a nice job of kind of categorizing the cervical deformity, right? There's the flat neck, the focal deformity, and then cervical thoracic kyphosis. I think they're just different etiologies. The focal kyphosis is in general a healthier patient with a single or two level cervical disease, and we're doing a cervical operation, and maybe we're calling it deformity, but it's really deformity light. I think the other deformities that we're seeing with the dropped head syndrome, that's a sarcopenia neuromuscular disorder that we're treating surgically, but we're not fixing the underlying problem. And so we're taking a medically complex patient, and then we're assigning a surgery to it, but we're not fixing the underlying neurologic dysfunction of the patient. And then finally, the cervical thoracic ones are the most deformed. So we've done something horrible to them. They end up with a horrific PJK, and then we're doing heroic operations around the spinal cord. And so we're then taking the most complex patients and doing complicated operations. Now, I think it's a combination of neurologic dysfunction and then intrinsic patient frailty is really what it is. These are sick patients. They're different than our adult deformity that kind of come walking in. These people usually come in with horrific cervical alignment and myelopathy, and you go, "Oh my God, I'm going to do what to you?" So I think they're just usually sicker patients. What do you guys think?
Launching off that question, one more thing on that topic, and I don't expect you to know the answer, but what's your feel in terms of weight between those two issues? Do you think that we see more challenge with this group because of frailty, or because the real estate's neurologically less friendly or more serious with respect to disability if it is compromised?
It's probably pick your poison. It probably depends on the complication, quite frankly. So I think the neurologic complications are probably much more related to the limited real estate and the risk of the operation. The dysphonia and dysphagia is probably a bit of both, right? As we get older, I think the dysfunction, intrinsic esophageal dysfunction that maybe we minimize after we make the spine rigid, then they're no longer able to compensate. And so, and then and then all the cardiopulmonary and late complications and DJK. I think that's probably a combination of both, or just the frailty of the patient, the poor bone quality, and then the stress that we're placing on these large corrections. And we're recapitulating the whole posterior muscular control, right? They've lost it all, and so we place it with screws and rods, and then we're surprised that it fails at the top of the bottom. We probably shouldn't be, but we have no other options, at least not right now.
Yeah, right. Is that you, Amber, with a question?
Yeah, I was going to ask, for the group 3s where you have a deformity distally that's resulting in deformity proximally in the cervical thoracic junction, how do you approach those patients, especially when they present with, more pressing concerns such as myelopathy, but it's the distal deformity that's resulting in the deformity proximally? It's hard to, I know, because we had a patient earlier this year that we ended up doing a huge surgery on because she had problems in both places, but it's hard to balance that cervical thoracic deformity when you know that it's worsened by the distal thoracolumbar deformity. Does that make sense? Does my question make sense?
Yeah, I'm gonna restate your question just a little bit. And so I think you can have, oftentimes you have patients that have cervical myelopathy or spinal cord compression, and then they also have malalignment. And addressing both of those issues is challenging. And you are right. You can have thoracolumbar or lumbar deformity that causes cervical deformity. I'd say it's much more common that we'll see like a significant PJK that is causing cervical deformity, like hyperlordosis, because of that malalignment. For me, the answer is, Amber, is I first focus on the neurology. And so if they're myelopathic, I try to figure out what do I need to do to address the myelopathy. And then if I can, usually the myelopathy and the cervical alignment go hand in hand, because as we're increasingly kyphotic, we stretch that spinal cord across that anterior vertebral column segment. And so I try to think about how do we fix both. If they're not myelopathic and it's a malalignment problem, then I think you have a little bit more leeway to try to think about how you can fix the deformity where the deformity is. The other bit is really focusing on the T1 slope. If the T1 slope is low, then typically the problem is in the cervical spine, and you can leave your deformity correction of the cervical spine. If it's high, greater than 23 degrees or so, in an abstract that we put out a few years ago, then there's a combined problem with both. And then at the very least, there is some thoracic kyphosis that you need to address or need to at least pay attention to. And in those cases, I typically think about a cervical thoracic operation rather than just a cervical only operation, or maybe even think about putting the correction lower down in the spine to help fix the alignment. So again, sorry, that was a long-winded answer, but number one, focus on the neurology. That's the most important. And then number two, then focus on the alignment and getting the alignment right. Sometimes that's not all the same operation. So I have patients that have myelopathy and they don't have much cervical deformity. And so for them, they can get a laminoplasty, allowing some flexibility. And then I go back and I fix a thoracolumbar problem. And so you don't have to fuse them T2 down to the pelvis. Rather, you can be thoughtful about fixing the deformity where it is and the compression where it is.
Okay, great. Thank you so much.
I don't know if that's helpful or not. Maybe not.
No,
All right,
it's
man.
helpful.
Anything else? Well,
Thank you.
thanks, Eric. We'll let you get back to your day.
Thanks, Eric.
Thanks,
Good luck
Eric.
with
Thanks,
the
guys.
transition.
Thank you, Eric.